Hello, happy Thursday today. I'm typically in here on Friday. I almost said happy Friday, but not quite yet. It is Thursday. So happy to join you today. My name is Julie Hirschberg. I am the owner of Re+active PT here in Los Angeles, and our mission is to help people with neurologic diagnoses recover movement, strength, confidence. We do this through brain-changing therapy, OT, PT, yoga therapy, exercise, and we also really are committed to helping grow and learn with other clinicians. So if you're new with us today, thanks so much for joining us. We're diving into a really talked about topic, at least in our PT circles, I will say. And we're talking about dystonia in Parkinson's. And this is a topic that comes up with our crew here at Re+active, but also just amongst colleagues quite a bit. And honestly, it like notoriously drives people nuts. It seems like, and especially if you look at the literature, man, there is nothing out there from a physical therapy standpoint. It just seems like it's very difficult to treat. And I think it can also drive the person who has it nuts, because it can really limit, especially if they're having it in their limbs, their ability to walk, use their hands, and things like that. So we're going to spend about 15 minutes together. So certainly this is not everything. But we're going to dive into a few key topics, which, by the way, if you are interested in diving into this more, we are doing a weekend course coming up in October, all on focal dystonia, as well as complex regional pain syndrome, CRPS. And we're going to be talking about Parkinson's dystonia as a part of that as well. But those two disorders, very distinct, have a similar neuroscience understanding, underpinnings, as well as treatment approach. And it's really fun to explore those together. So that'll be coming up in October, but I just wanted to let you know if you wanted to go deeper in this subject. So today we'll hit on a few pieces that I think are important when we think about dystonia and Parkinson's. The first thing is understanding, is this actually Parkinson's or maybe a Parkinson's plus syndrome? Very different when it comes to the effect of treatment, the responsiveness to their medications. And when we think of things like maybe cortical basal degeneration, just a different prognosis altogether. So that's probably the first piece that that's important that we'll talk about. In Parkinson's, so if it's in idiopathic Parkinson's, most commonly we see it in the foot, can be also elsewhere, but we'll talk about what that might look like. And I'll also refer you actually to our Camp to Cornea talk, because that was really about dystonia in the trunk for somebody with Parkinson's. So we won't dive into that today. We'll talk a little bit about the medical management and what we know there, and the PT management. This is the most fun part for me, for sure. So I brought a couple little fun things to show you, some creative ideas of some things that we do. So thank you for joining us, Betsaida, Allison, I see you on here. Excited to have you join. So let's start with this idea of dystonia in the differential diagnosis process of Parkinson's. So certainly we as physical therapists are not giving this, this diagnosis, but it's important for us to be aware of it. So one of the things I typically see here, oh, Jennifer is joining us. Hi, thanks for joining us. Love to see my PT friends here. So one of the things I think about is that a very prominent dystonia can be a sign of a Parkinson's plus syndrome. In a recent article where they looked at Parkinson's plus syndrome, what they found is, in this particular study, now that these vary a little bit, 11% of people with idiopathic Parkinson's had dystonia. And I've seen that range from like 11 to 30%. However, if we look at the Parkinson's plus syndromes like MSA, 20%, PSP, 40%. And then probably the one that like I think about the most is CBD or cortical basal degeneration. 66.7% of people with cortical basal degeneration have dystonia. So definitely the most frequent in that Parkinson plus category. People with MSA tended to have, in this particular study, dystonia in several different parts of their body. And in cortical basal degeneration, it was much more of the limb dystonia. And I think for me, the hallmark that I typically see is in the hand and upper extremity. And what's important here is that I think that's even more difficult to treat because it doesn't typically respond to the changes in medication, and it's more progressive. So it's not to say that it's not treatable, because I have treated it. And what I would say from my treatment plan standpoint, I'm looking at maintaining their range of motion, the use of their limb for as long as possible, weight bearing, using that limb as long as possible, preventing a rapid decline and contractures and things like that. So that is the differential diagnosis piece, is really thinking about, is this dystonia part of a Parkinson's plus syndrome, or is it part of idiopathic Parkinson's? And that would be the first piece of understanding. Now, some of the literature has said that typical dystonia is not very common in an untreated Parkinson's disease. Now, they say that, however, it is more common in somebody who has a young onset Parkinson's. So go figure. But I think what the point is there is oftentimes the dystonia might be coming on with the use of medication. So that's important piece to think about. So first of all, in idiopathic Parkinson's, not everyone gets dystonia. It can happen at any part of the disease process. It might be in up to 30% of people with Parkinson's. Some of the things that have been shown as more common, and I think I have seen this as well, our clinicians have seen it, more likely to happen in the morning, before the first dose of medication, or it can happen during the day, kind of in a wearing off, like before the next dose of medication. And then you see those other symptoms of wearing off at the same time. And so those are a little easier to classify in that off-time dystonia. As I mentioned before, it is more common with people who have a young onset diagnosis, so less than 40 or 50 years old. And that's definitely been my clinical experience as well. One of the most common places that we see it is in the leg or the foot or the toes. So cramping in the toe flexors, supination, inversion of the foot, plantar flexion. It may also, and there's been some case reports of this, demonstrate or show up and look like a foot drop, but really what it is overactivation of the plantar flexors. And I'll talk about a case at the end today where that's really what it looked like in a patient that I worked with. But it can show up in other forms. I think we're going to really speak to the foot, because I think that's one of the more difficult to manage, and like the functional impact is huge. It can show up in the eyes like a blepharospasm, and there are actually some really creative things there. Some adding weighted eyelashes. This is something that the brilliant Allie Elder did with a client of ours, can really help with that. It can show up in the neck, in the face, in the trunk, and we talked about the trunk in our Camtocormia course and our Camtocormia Facebook Live as well. So it can show up in different areas for sure, and each of those areas might respond a little bit differently to the types of management. So I want to talk about medical management. The literature does have some small research studies, some recommendations here, but honestly, no one better than the amazing Alan Wu. He is a movement disorder specialist that we work really closely with. He's at UCLA. He does really primarily dystonia. He also does a lot of functional movement disorders, but that is the mainstay of his practice. And he is a big part of our fellowship program, our movement disorder fellowship. So when we're in discussions with him about the management, I just really love his approach. And so I wanted to kind of give you his advice and show you how that lines up with the literature. So first line of advice when you're seeing this is to check the medications. And what I see, what the literature shows, is making modifications can have a really big difference. So the Parkinson specific meds, the Sinemet, the dopamine agonists, sometimes the amantadine, sometimes anticholinergics can all contribute, and changing the schedule is often a piece that really can take it away, to be honest. So that's very, very good news. And it's a lot of guess and test with the movement disorder specialist that not guess and test. It's not guessing, but it's testing and trialing to see, okay, well, let's see if we change the schedule to every 3 hours, if that prevents a wearing off dystonia. Now, the other thing is that the dystonia can be a form of the dyskinesia and too much medication. And so tricky, because it could be too little or it could be too much. And again, playing and moving the medications around to see where it responds. That's the first step. And that's where I personally have seen the most success for our clients, when they work very closely with their movement disorder neurologist to make those little bitty changes. My experience is that it's really a movement disorder neurologist who's very good at finding that fine balance for somebody. So I recommend all of my clients with Parkinson's have a movement disorder specialist to be able to help with this process. The second piece, so manage the medications. If that fails, looking at considering Botox. So Alan Wu basically said this is variably successful, 50 to 60% success. And it's so interesting because a recent research article in this basically had 48% success rate. And I was like, wow, okay, he's right in line with the literature. It can be tricky to figure out exactly where to inject, and this is where it's really nice for a movement disorder neurologist to work hand in hand with a physical therapist, do a gait analysis, and really determine what muscle is most overactive. So that's one piece. In this recent study they did in Botox, this was really interesting. They compared it to a placebo injection, and they were doing toe flexors. They found that the Botox was superior to placebo in that clinical global impression of change, which is great. However, the Botox and the placebo both got better in pain and dystonia. So there you go for the placebo effect of influencing change there. So I think that's a pretty great placebo effect, and pretty positive outcome, but it was also a fairly small study. It might not have been powered enough to show change, but certainly something to be considered if medications fail. Deep brain stimulation is another option. It can help. It can also cause dystonia, so very tricky. I think this takes a very careful examination, work of the movement disorder neurologist with the therapist again to help make that determination. Definitely not a one-size-fits-all treatment, and it's so important to have that collaboration with the movement disorder neurologist to find that best regimen to work. So now the fun part. Let's talk about PT management. And I literally have spent the last month trying to find something out there for PT management, and there is really literally nothing. By the way, if you've got something, please send it my way. I feel like a very strong desire that we need to publish and at least get a case study out there. It was not to be found by me, and I literally have been looking for the last month. One thing I did find was a series of articles in the osteopathic medicine literature looking at dystonia treatment in Parkinson's of different limbs, and looking at some of the manipulation techniques in managing that. And some improved results, especially with pain. And I think that can really carry over into our physical therapy world, excuse me, for sure, but not an overall comprehensive management. So what I'm going to talk through now is some of it's a theoretical basis of dystonia management, but also our clinical experience here at Re+active. And we've got 8 neuro-PTs. We primarily work with movement disorders. We have our movement disorder fellowship. So we have clinical experience, and gosh, I guess we need to publish some of this. So let's talk a little bit about that theoretical basis, our experience. And I think one of the key pieces, because I love talking about dystonia, this in Parkinson's is not your idiopathic dystonia. It's not like a writer's cramp or a runner's dystonia or a musician's dystonia. It's not happening from overuse and neuroplasticity gone awry. And I think that's an important distinction. And treatment, there are some really nice overlaps, but treatment can be very different because of that. But there's similarities. So we know similarities in Parkinson's and dystonia, especially just even the origin in the basal ganglia, sensory processing and awareness, variability of movements, stiffness and overall movements, impaired postural writing responses. Here are some similarities in our idiopathic dystonia and Parkinsonian dystonia that we can address. So I'm going to go through, gosh, I got 6 main points in the PT management part. One big piece that I think is kind of the low-hanging fruit is investigating any underlying issues, biomechanical issues, sensory integrative issues, balance, nervous system regulation issues. What do I mean by that? So biomechanically, is somebody limited in range of motion, joint mobility, muscle activation, force production that would contribute to them overusing, overactivating a certain group of muscles? I'm not going to say that's an easy fix, but that's something that can be addressed right away and at least limit the impact of the dystonia on their function, walking, running, things like that. Sensory. What do I mean by that? 2-point discrimination, proprioception, kinesthetic awareness, sensory discrimination, like a stereognosis, graphesthesia type of piece, because we can influence that as well. Looking at balance, nervous system regulation. What I'm really talking about here is when that person comes to me and tells me, you know what, when I get really anxious or stressed or really nervous, the dystonia gets worse. Okay, well, I'm not going to take away stress and anxiety, but I can help you in the way that affects your body. My OT actually is super good at this, right? And our yoga therapist, right? So nervous system regulation can be huge. It's not removing the dystonia, but it's reducing some of that nervous system sensitivity. Okay, when we talk about that biomechanical, a huge piece of this, so I kind of put this as number 2, was providing, maintaining, increasing joint mobility. This is where I've really seen a big effect. Often when the dystonia is like influencing function and preventing, and they're coming to therapy, it's been happening for a while, and they already had a contracture or starting to lose joint mobility, and just regaining some ankle dorsiflexion, toe extension, range of motion is very helpful. Basic PT, manual therapy type of stuff, which is awesome. Number 3, and this is probably where I get the most bang for the buck, is improving weight bearing through the limb. Again, basic for us, but very, very effective. And incorporating that with the next piece, which is sensory training, doing stuff with eyes closed, different surfaces, discrimination in the feet, using that fun little bowl of beans or rice with all those objects, but doing that with the feet, super weird and fun. And like, I make their own rice bowls, so people's like toe jam aren't sharing with others. Sorry, that was kind of gross, but true. I wanted you to know, very cleanly here. Part of that, and so I brought a couple little props that I love to use. These little half-body glasses, they're like this, so you're not visually seeing the lower body. How about these puppies? These are really fun. Woo! So we got lights going, we got lines there. So being able to challenge the sensory system with balance, with walking, with standing, and doing that in a way, initially, boy, you put these puppies on and that dystonia is going to get a lot worse, but being able to progress to this, I liken these to walking through Las Vegas, right? So just fun ways to progress some of the sensory training stuff. Working on motor discrimination, so individualizing foot and toe movements, small movements as well. You know, we want to improve usually the weight bearing position, so small movements in standing and in weight bearing where they're isolating foot and toe movements, and increasing overall activity levels. So I want to just give you a really quick case here. In my experience, it doesn't just take like one of these things. Like if you just did the joint mobility, I think you're just getting like 1/10 of it, right? It takes a holistic approach and addressing it at all angles. So I want to give you an example of a person where we did that. I saw her really soon, maybe within 2 weeks of her initial diagnosis of Parkinson's. She was younger. She had toe drag and what looked like foot drop. But after examination, talking to her, looking at her, it was very clear she had dystonia, overactivation of her plantar flexors and toe flexion. She had some very mild balance deficits because, and like due to, but also like causing less use of her involved side, overall less weight bearing on that side, overall less movement on that side, overall less variability, right? And I think this is what we see: decreased arm strength, decreased rotation, decreased variability in the movement of her lower body. So we could address all of that. We're able to do a lot of fun activities like our half body glasses, like eyes closed, crazy surfaces like on the Bosu ball, river stones, pillows, tons of stuff to increase weight bearing on the leg. One of the things she saw is like if she was sitting for a long time, when she woke up in the morning, when she didn't have any weight on the leg, the dystonia was worse. So we got weight down, weight bearing through her legs, her using that side more. We added head turns, trunk rotation, dual tasks. This was a huge one for her. But probably most significantly, holistic approach, we really coached her through generally increasing her activity level and her aerobic exercise. She started walking several miles per day with a focus on her symmetry and variability. And honestly, toe drag went away. No dystonia. She did not have to have Botox. She didn't have DBS. Over time, at that time, she was on no medication, actually, which is a little unusual. No changes in her medication. I really think her biggest thing is that she increased the use of that limb and that normal sensory input through the limb. Physical activity, forced use of her basic principles. I think good old-fashioned stuff. She needed that whole package though, right? It wasn't just one of those things. So I think that's really important. So there you have it. 6 pieces of a management program that go hand in hand with medical management for Parkinsonian dystonia. I do see that it is harder to influence. It takes longer, in my clinical experience, than some of the other dystonias to influence. There's not usually a sensory trick or one thing where we can see it disappear, and I think that can be really challenging. So I hope that was really helpful for you all. As you know, I'm really passionate about dystonia and this type of topic. We had, we have a dystonia course that is online. I told you we have our weekend course coming up in October on focal dystonia and CRPS. We also, if you haven't received it already, we have these great cheat sheets on assessment and treatment in cervical dystonia, very applicable to this population as well. If you don't have those already, I'd love for you to have them. They're very PT oriented. You can go to reactivept.com/dystonia. We'll send you those updates and we'll keep you updated. Like every time I create something in my practice, I try to share it with you all. So would love to share that with you. A couple of questions here. Betsaida asks, have you found sensory tricks for the foot? I have, Betsaida. The sensory tricks that are most helpful in the foot are changing the direction of movement. Backwards, sideways are the biggest pieces. Changing the position of the foot, so feet out, feet in. Changing the sensory component. So this might be a different insole for them. This might be, I've tried these like funky little acupressure insoles that have been helpful. I forgot to mention, and I've heard a lot of other PTs say this as well, toe spreaders help, and you can like buy them at CVS, right? But they're also, my favorite is the toe spreader that you can make yourself that's custom for them. It has this nice little like piece of arch and it uses moleskin and it's custom for them, and you can use it in their shoe. Those kind of act as a sensory trick. TENS, I haven't seen TENS as successful in Parkinsonian dystonia, to be honest, but you know what? Like, I like to try it all, to be honest. I really do. So taping, some people are super responsive to kinesio tape, and that has been helpful. All of these I would put in that bag of sensory tricks. And it's great to have a bag of sensory tricks and go, how about this? How about this? Let's try this. Let's try this. To me, it's akin to a physician going, okay, we're going to try the dopamine agonist, we're going to try Cinemet, we're going to change the schedule. We're doing the same thing with our treatment as well. So thanks for that great question. Thanks for really being dedicated to helping people with this diagnosis. It can be really tricky. They can be told that there's nothing that they can do, or even be told there's nothing PT can do. And I think there's a lot we can do to help them decrease dystonia and manage it as well. So thanks again. Thanks so much for joining us. Again, you can grab some free resources at reactivept.com/dystonia. And I will see you again soon.